Hello nurses, what's going on? It's another practice essential video for you. In a variety of settings in our practice, we nurses are increasingly likely to care for patients on mechanical ventilators. Therefore, I'm going to discuss mechanical ventilation and the nurses' rules and responsibilities in caring for mechanically ventilated patients. Alright, so let's assume you're one of them or become one of them. What do you need to know to plan for your shift? Which patient assessment parameters are crucial and what evidence-based practice guidelines should you follow? So let's start by discussing mechanical ventilation. This is a broad topic, so I'm gonna be very specific. I'm not going to discuss ventilatory modes, variables, and nurses' responsibilities or anything like that in this first video. What I'm gonna do is to simplify the topic to the most specific key points that will touch all essential concepts of mechanical ventilation for you to grasp the concept and science behind it. Alright? I might miss something important, so please have time to study mechanical ventilation. This will help you. But I'm sure the things I'm about to say will give you a heads up. Okay? Now, what have in your mind when you hear mechanical ventilation? It's a machine that breathes for an ill patient or aid the patient to breathe, right? Because normally when we breathe, we inhale and exhale. Count that cycle in a minute and that is your RR or the respiratory rate, right? Each time we breathe, we're taking tidal volume. That's the amount of gas we're taking inside our lungs and exhaling. Sometimes we take a deep breath, so that's a high amount of tidal volume, like that. And then sometimes we take a small breath, so we have a small amount of tidal volume. Tidal volume is pertaining to a certain amount of gas per breath. When you ask what is that tidal volume gas about, well, it's a mixture of gases and oxygen. Essentially, our atmosphere or the room air is a mixture of gases, and it contains 78% of nitrogen, 21% of oxygen, and a percentage of other traces of elements like carbon dioxide or water vapors. When we breathe, in, we inhale the same mixture of gases contained in the atmosphere, as our nose cannot filter out the oxygen from other gases. In mechanical ventilation, we plug the machine into the medical gases and oxygen supply in the hospital. Now, medical gases is the same as room air. It contains roughly 21% of oxygen and 79% of other gases. The oxygen, of course, is a supply of 100% oxygen. The blends of this mixture of the gases are the ones we are giving to our patient to deliver a set amount of FiO2. FiO2 is the fraction of inspired oxygen. Typically, we set the amount of FiO2 we want to give to our patient. You can deliver up to 100% if required. So, when we talk about respiratory rate, it is the number of breath in a minute. Tidal volume is the amount of air that moves in and out of the lungs with each respiratory cycle or breath. So that is one breath only. When we talk about FiO2, it is the concentration of oxygen in the gas mixture. We set FiO2 based on how badly patients need it. Therefore, arterial blood gas is needed to determine the oxygen saturation and the partial arterial oxygen of the patient. Because you cannot randomly give oxygen to the patient. We need to determine if they need it. High oxygen is a toxic. So, did you get it? Alright. The doctor orders the settings of the ventilator according to the patient's needs. Let's say the patient is not breathing. So the physician ordered mandatory mode ventilation and set the respiratory rate to 12 per minute. The ventilator will set this to 60 seconds divided by 12, which is equals to 5 seconds. So the Benz gives breath every 5 seconds. What if we will set to 20 per minute? The ventilator will adjust to 60 seconds divided by 20. So it is equal to 3. Therefore, the vent will deliver breath every 3 seconds. How about tidal volume? How to set the tidal volume? A safe tidal volume can be determined based on the patient's height, gender, and ideal body weight. It ranges from 6 to 8 ml per kg of ideal body weight. That is around 500 ml in an average healthy adult male and approximately 400 ml in a healthy female. This is the formula, okay, as you can see in the screen. This is how to get safe tidal volume, okay? The set respiratory rate and tidal volume together, it gives us minute ventilation. It's another important ventilation parameter. Minute ventilation is the total amount of tidal volume in a minute. So it is calculated by multiplying tidal volume with the respiratory rate. For example, set rate is 12 per minute and tidal volume is 500. Therefore, you have how much? 6,000 ml or 6 liters of minute ventilation or minute volume. Got it? Now, the question is, how does the ventilator know when to give a breath? Okay? The mechanism of a ventilator responsible for that is the trigger. The triggering mechanism determines how a mechanical breath is initiated. The variable also determines whether a mode of ventilation can be described as mandatory or spontaneous. Mandatory means that the machine controls the breathing, and on spontaneous, the patient breathes on its own or in synchronization with the machine. Historically, breath initiation in mech bands is purely machine-driven affair, but with the advent of the microprocessor controlled ventilators, mechanical ventilation has become more user-friendly, where the user, of course, is the patient, not the healthcare provider. Okay, we are the manipulator, what you call that. We are the one who's adjusting the vent. There are different mechanical ventilator trigger mechanisms, such as time triggered, a patient triggered. When you set the ventilator to time triggered ventilation, it will measure a period since the last expiration and then deliver a breath. For instance, you set the rate to 12 per minute. The ventilator will deliver inspiratory flow exactly every 5 seconds because 60 seconds divided by 12 is 5 seconds, right? Therefore, this is characterized as mandatory because it is implying that the patient has no choice in the matter. Okay. That is why trigger mechanism determines whether one's mode of ventilation is mandatory or spontaneous. Okay? Excuse me. A time trigger mode is always mandatory, as I've mentioned. And in patient-triggered ventilation, it permits the patient to have some control over the timing of inspiration, whether it is triggered by flow or by pressure. Flow trigger is when the patient sucks flow out of the bias flow from the circuits in an effort to inhale. The mechanical bend sense this and initiate a breath. Okay, what is bias flow? Bias flow is a gas constantly circulating in the ventilator circuits. Let's say 5 liters per minute of bias flow is set. When patients suck some of this flow of these 5 liters in an attempt to inhale, The ventilator sends this because of the deduction of the flow. This will tell the vents that it's time to give breath, and it will be instant. Okay? On the other hand, when the patient takes pressure from the circuits, the mechanical ventilator initiates a breath, and then it is the pressure trigger ventilation. Okay? In addition to that, there are some triggered ventilation, other triggered ventilation mode, like shape signal triggering, and then what is the other one? I forgot. Yeah, the neural assist or the NAVA triggering. Okay, still with me? Okay. Now, the next thing we have is cycle. Cycle is what ends the inspiration and starts the expiration. Normally, we actively inhale and passively exhale, right? In mechanical ventilation, that's the same. Inspiration is active, but expiration is passive. The cycling mechanism of a ventilator depends on what mode is set, and it occurs after set value is reached. All mechanical ventilator bridge types are governed by cycling variables. 4 variables are used to determine when to cycle to exhalation. These are the pressure, time, volume, and flow. For example, in pressure cycling, the most common application for pressure cycling is for alarm settings, or is the alarm setting. If patient becomes extremely asynchronous, or the patient is coughing, the high pressure alarm will be triggered and the inspiratory pace ends, resulting in exhalation. In time cycling, it can be accomplished by setting the respiratory rate, inspiratory time, or inspiratory expiratory ratio. Many ventilators terminate the inspiratory pace after a certain time frame, which is typically 3 to 5 seconds. Okay? You got it? Alright. Because we're talking about the air here, and we're putting that air inside our patient, the pressure is beneficial, but it can be detrimental. Imagine, if you put a lot of air into the balloon, what will happen? Okay, what will happen? Eventually, it will burst, right? Same scenario if it will happen in the lungs. And this is called, the complication called barotrauma. So, we need to monitor the pressure. The pressure we need to take care here are the peak pressure, plateau pressure, mean pressure, and the PEEP that we typically set. Peak pressure is the sum of airway pressure plus the alveolar pressure. Plateau pressure is the pressure or air in alveoli and small airways. It can be measured during an inspiratory pause on mechanical ventilator. Usually the respiratory therapist and the doctors are performing this maneuver on the ventilator. What they do is that they are holding the breath at the end of inspiratory peak. Once they do that, the pressure will go down to the level of alveolar minus the airway pressure. So in the level of alveolar and small airway pressure. Not all the airway, only the small airway pressure. And it will stay there as long as they're holding that breath. So the plateau pressure is the representation of the alveolar and small airway pressure. How about mean pressure? Your mean airway pressure is the average pressure your lungs are exposed to during mechanical ventilation, both during inspiration and expiration. The average of all pressure during the breath cycle is your mean airway pressure. It's like the average of your grades in a whole semester. The lower your marks in your subjects, the lower your general average is, right? So the analogy to that is that one, your grades. The higher your peak pressure and the plateau pressure, the higher your grades. I mean your airway pressure, mean airway pressure. Now, how about the PEEP, or the positive expiratory end pressure? This is the pressure we set to prevent the alveoli from collapsing. Normally, the lungs do not collapse even after forceful expiration, because it is not empty no matter how forceful the air is exhaled. There will be a residual there, okay? The minimal amount of leftover provides oxygen to the cells and prevents them to deflating and collapsing. So, the same on the mechanical ventilation. We set the PEEP to prevent alveoli and lungs from collapsing. Okay? Let me give you an illustration. Okay, on the screen, that's the illustration of the waveform. That's a pressure waveform. This is the peak pressure. This one is the plateau pressure. The area here is the PEEP that we set. This all area here is the representation of the mean pressure. Okay, that's it. Wait. I almost forgot. I need to mention this because it's worth mentioning. In the management of ARDS, routine application of driving pressure is under study and maybe will help in decreasing mortality and improving the management of acute respiratory distress syndrome, or ARDS. Driving pressure is the plateau pressure minus PEEP. It can also be expressed as the ratio of the tidal volume to respiratory system compliance. So the difference in this area is your driving pressure, this area here. Okay? That's the end of our topic. Okay. I hope did you follow? I believe that the information I've mentioned is the most essential in understanding mechanical ventilation. You will not be competent in handling mechanically ventilated patient if you don't know this. Otherwise, when you see a patient having a respiratory rate of 10 but the tidal volume is 500 ml, then you will call the doctor or the respiratory therapist and will say, my patient is hypoventilating. Well, that is not hypoventilating, because 10 times 500 is 5,000 or 5 liters. It is very good minute ventilation or volume. Hypoventilation is when you have a low minute ventilation that result in an increased accumulation of carbon dioxide, or PCO2. Hypoventilation or hyperventilation is not decreased or increased in respiratory rate or tidal volume alone. So you have to understand how these parameters play along. Got it? There's more about mechanical ventilation that we cannot grasp in one go without going to the university or taking a respiratory therapy course. It's another field of study and profession that happen to be part of our profession as a critical care nurse. In an ICU or critical care setting, the respiratory therapy is often available 24/7. However, their numbers are not enough. In my previous experience, we don't have respiratory therapists. We're forced to manage some mechanical ventilator issues. Now, in my current workplace, the respiratory therapists are available, but they are understaffed. Okay? So, we're done. Next video, we're going to talk about modes and basic components of the mechanical ventilator, and then the nurse's roles and responsibilities in handling patients with mechanical ventilation. Okay, so this is really important in our profession as a critical care nurse. I hope you've learned something and the video will help you in your practice or future endeavor. Okay, good luck. Thank you.